I will introduce our second panelist, Dr. Animesh Tandon. And Dr. Tandon is a good friend, is a physician scientist and pediatric cardiologist who specializes in cardiovascular MRI. His research interests include using multimodality data streams, including imaging, clinical data, as well as the variables, and advanced analytics to improve diagnosis and prognosis for children and those with congenital heart disease. He recently started about a month ago a position as Director of Cardiovascular Innovation at Cleveland Clinic. So welcome, Dr. Tandon.
Hi, Arpit, and everybody in the audience. Thank you so much for inviting me to this panel. I'm going to focus mostly on 3D printing and virtual reality. If you have any questions, obviously at the end, or just email me. I don't check Twitter quite as often, so email is probably the better one. But my disclosures are that we co-founded a company and advising a different company about how to use virtual reality in medicine, and some of the products are mentioned in the talk. So I wanted to start by just detailing what some of the different technologies are that exist, so it's clear what I'm focusing on. Virtual reality is the technology you might be most familiar with, where the user wears a headset that blocks the whole field of view, but yields a fully immersive experience. And so if you've used a Vive or an Oculus Rift, that's what we're talking about. On the other end of the spectrum, augmented reality uses a see-through display to display virtual objects over the real world. So an example is Pokemon Go on your phone, or the HoloLens. And these can be used in different parts of the procedural process. So since VR blocks the view, it's hard to do a procedure with it on, while augmented reality is starting to be used more, and Dr. Agarwal will discuss that more in his talk. So I'll focus mostly on 3D printing and virtual reality. So the process of going from the raw DICOM image to a 3D model starts with excellent imaging. As Dr. Davo mentioned, you have to have good images to start any 3D process. And then, at least as of today, you have to do a task called image segmentation. So in this process, you have to highlight the pixels or voxels that you want to keep, right? So you color them in, kind of like an adult coloring book. And this step is necessary because you need to make sure that the anatomy that's being generated is correct. You have to get rid of the lungs and all the other stuff that you don't necessarily want. And then there are various software that can be used for this process. That yields a 3D file, often in the STL file format. Then you have a choice. You can go down the 3D printing route, where you send it to a printer and then do post-processing and then end up with a print, kind of like the one Dr. Davo showed. Or you can take the 3D model and pull it into the virtual reality space. And so I hope in the future that there are more automated techniques that will speed this process up, but segmentation is definitely one of the major limitations to the use of 3D technology in clinic today. So why would you want to do 3D? Why use virtual reality? I think this paper in Nature really sums it up well. It requires an enormous amount of intellectual work to construct a 3D model from a 2D screen, but all that work goes away when you put on the goggles. And the technology feeds information to our brains in 3 dimensions the way 1,000,000 years of evolution intended. So as you heard, right, our goal as imagers is to make sure that we, the surgeon, and the patient have a mental model of the anatomy. And you can think about a 0-dimensional way to describe it, which is the report, right? Okay, 1 centimeter past here, there's this coarctation, right? And then you can see 2-dimensional ways of thinking about it, which is what you see on a 2D screen. And then you can say like 2.5D, which is when you're looking at a 3D object on a 2-dimensional display. But real 3D, right, is this. And then eventually there'll be 4D, where you're able to see functional stuff. So all of this is technology that's being developed. So today I'll cover some of the uses of VR and other types of reality in planning procedures in congenital heart disease, and then some barriers to implementation. The first example I wanted to give is about sinus venosus defects. So as you know, one way that we use 3D or other technologies is for patient selection. So in in sinus venosus defect, as you all remember, if this is anterior and this is posterior, there's a defect in the posterior wall of the SVC or in the anterior wall of the pulmonary veins where pulmonary veins can drain into the SVC, and that allows mixing of systemic and pulmonary venous return. And there's a broad range of anatomic variants, with the location of the defect and connections being especially variable. Sometimes placement of a covered stent can be used to treat this without surgery, the goal of which is to close the sinus venosus defect while allowing unobstructed pulmonary venous return to the left atrium. And these procedures are often planned using preoperative cross-sectional imaging such as CT and CMR, though there's been some papers about how echo is sufficient. I'm not sure I agree with that. But there can also be done using 3D printing. So in this case report with some of my friends in King's College London, they had generated a 3D printed model of the sinus venosus defect and then basically planned putting a covered stent in the 3D model. They did a CT of that model and reconstructed it. And then lo and behold, that's exactly what they saw when they did the procedure in the cath lab. Here's an injection into the SVC where you see there's no drainage to the pulmonary veins. We took this one step further and did the anatomic evaluation for 28 patients in the virtual reality space. So we took CT and MRI images, generated 3D models of 28 sinus venosus patients. We then looked to see if they would be candidates for covered stent placement. So here so the SVC in the atria with most of the rest of the heart cut out. And we're just, doing something very simple, which is putting a cylinder into this SVC. The SVC, the cylinder needs to be a little bigger than the SVC because that's how it's going to sit. And you can see as showing there that there's a gap in where this what the stent covers, right? There's still a defect there, so that stent is insufficient. And so what we do here is we take that quote unquote stent out, and we put a fatter stent in that's still within the size guidelines, won't damage the SVC. And then we are able to manipulate that in the 3D space. So here we're showing how we verified correct stent placement. The pathway of the pulmonary veins are marked with red arrows over here. And you can see whether there's a residual defect. First, we're checking it from the right atrial side. There's no residual defect here. Then we turn the model and we check it from the left atrial side to see if there's a hole back there, right? And the advantage of virtual reality is you can stick your head in, right? So you can stick your head into the left atrium and really see, okay, here's the SVC drainage, here's the pulmonary vein drainage. That blue line was the anomalous vein. And we're trying to make sure that all the veins drain to the left and SVC drains to the right without any obstruction. Here's an example where the covered stent would have blocked a large pulmonary vein. You can see that large pulmonary vein up here and over here. This is the defect that's actually closed by the stent. But the problem is that when you go and look from the pulmonary vein side, this pulmonary vein will get blocked by the covered stent. And so using this technique, we found that of the 28 patients, 11 would have been theoretically suitable, 7 would have been equivocal because either you would have had a small anomalous pulmonary vein would have been blocked or there would have been residual left-right shunting. And 10 were not candidates as we thought because either a large vein would have been blocked or they had specific anatomic subtypes that would have prevented successful placement, such as biatrial connection where the SVC sits on top of the atrial septum. So in this project, the VR environment provided 3D information about anatomic relationships that were not immediately obvious on 2D imaging, and thus provides an excellent platform for planning patient-specific interventions. This work is coming into the TAVR TMVR transcatheter mitral valve replacement and left atrial appendage technology as well. There's an excellent review by Didi Wang, actually at Henry Ford Hospital. Here they're doing virtual and 3D printed models of the transcatheter mitral valve placement to see what the residual neo left ventricular outflow tract was going to be. And you can model different placements of these transcatheter mitral valve replacements. And then using these kinds of printed things to look at the left atrial appendage as well. And in some reviews, they found that when authors evaluated where 3D printing was reported to be used in the literature, combined between papers where 3D printing was used, LA appendage procedures was the leading reason to do 3D printing in about half the cases. But it's also being used for TAVR, mitral valve disease, AV valve regurg, coronary artery anomalies, et cetera. Dr. Adebo mentioned this briefly, but there is use of 3D imaging in electrophysiology procedures. He showed the overlay of the CT, and there are actually other case reports about using 3D printing and virtual reality and augmented reality for both planning and intraoperative guidance. And this team suggested that the 3D print allows a real size assessment of the geometry and even allows inserting the medical device to predict possible anatomic challenges about where the catheter might get stuck in this patient with an atrial switch procedure. Dr. Adebo mentioned VAD candidates. I'll go into that a little more detail. Here, in children, right, they're borderline BSA from the FDA clearance for the devices. And basically, it's not always guaranteed that a VAD will fit, and BSA is only an approximation of patient-specific geometry. So here we used the virtual reality system, kind of like what Dr. Adebo showed, where we defined the AV valve plane, and here's the heart, and here's the chest. And here our cardiac surgeon is evaluating the use of whether this device will fit with sufficient space between the AV valve and the inflow of the device. And in this series, we presented 3 images of similar sized children, BSA 0.67, 0.66, and 0.65. And we evaluated whether the HeartMate 3 VAD would fit in the rib cage while being at least 1 centimeter away from the plane of the AV valve. And despite being heavier than the other 2 patients, the first patient had the shortest distance from the AV valve to the chest wall. We didn't proceed with the HeartMate. And again, the VR system allows a more personalized evaluation of patient-specific geometry past what BSA would indicate. You can see here, we're inside of the heart, looking at the orientation of this device to the AV valve plane. Here again, we're looking at that personalized geometry in two different chests. This is just a 3D version of the same video. If you're able to view this in a 3D headset, you get some depth perception. And so this kind of technology has allowed us to, in Dallas, to place the HeartMate 3 in 2 of the smallest patients described in the literature to date, both with body surface area less than 0.8. And then finally, we'll talk about education. You can do parent education with 3D technologies. Here in this paper, Dr. Taylor's group at Great Ormond Street ran a randomized controlled trial to see if 3D printed models were helpful in doctor-patient communication. And though parents and doctors reported that the models were helpful, it didn't increase the 3D knowledge more than the 2D drawings. Likewise, multiple studies have looked at using 3D printed models for trainee education. In most studies that I could find, learner satisfaction is higher with 3D printed models, but the studies have mixed results about whether trainees learn more with the 3D printed models. And then we are actually working on using virtual reality to do teaching in the VR space. So we actually created some virtual reality videos that will be available on YouTube soon about vascular rings. We created an idealized vascular ring, right, like this Edwards model of it. And then we use patient-specific anatomies as well, kind of like what Dr. Adebo described, to show this anatomy in depth. And then here's another example of this for looking at double aortic arch. So in terms of future directions, the barriers for implementation are really the software and the hardware is not always widely available, but it's growing. And then it's hard to run randomized controlled trials in congenital heart disease. So getting funding to support this work is harder, and to build the evidence base. And then there are various technological challenges like image segmentation and registration. And then we can talk a little bit about 3D printing versus virtual reality. There's a lot of shared workflow issues. But I think the biggest thing is that these technologies help us create a shared mental model of the anatomy, which I think is really the goal of any imaging modality. And we can work on developing this technology to make it easier for us to have a shared vision of the patient and derive patient-specific anatomies. You know, when people talk about precision medicine in adult world, we've been doing that forever in congenital heart disease, right? Because every patient is different. With that, I'd like to thank the organizers and my colleagues, and I'll take questions at the end. Thank you.
Thank you very much, Animesh.